When we think about laboratory professionals and clinicians, that interaction, you've got many years of experience here. And we tend to know that, over the years, we talk about silos. That's an often used term, and kind of know their own duties and what they're doing. Why do you, in your words, think and you've kind of talked about this, but why do you think it's so critical that laboratory professionals and clinicians get together when it
Yeah.
comes to a diagnosis?
Well, I think it's all based on need. So when you get evaluated when you're sick, do you always get an imaging study? Do you sometimes get an evaluation? But nobody does a chest X-ray every time you come in or some other test. And do you get biopsies? No, most of the time, no. But do you get lab tests? Every time you get lab tests. And so I started with thinking that doctors didn't know the complicated stuff. So from coagulation, we thought, oh, okay, maybe we need to just say we'll deal with the complicated bleeders and clotters. And then they said, well, we'd like your help with these cases. And I thought, oh, those are like simple liver function tests. And then maybe these cases. And then I realized that they didn't know what it meant to have an elevated red cell distribution width, and that's part of the CBC. And then the New England Journal of Medicine started coining a term called pajama time. And when you read about it, what it means is that some poor family practitioner, general internist saw 14 patients in a day. And now, as you would guess, because we call the normal range the middle 95%, people fall off the edge. And so somebody's that they saw is going to have abnormal lab tests. Maybe one abnormal lab test for everybody they saw. That's 14 calls. And they don't know what it means to have reduced or an elevated red cell distribution width. Let's just go down to MCV. How big are the red cells? You have folate deficiency, B12 deficiency. These are fixable things. You don't want to miss these. So the reality is they didn't know that. And that's when I figured, whoa, now we can potentially really help them. And so what has happened to us now, which is really exciting, is that I was approached in July last year by the Seeley Smith Foundation, which is the major philanthropic support for the University of Texas Medical Branch at Galveston. In fact, our med school is named the John Seeley School of Medicine. So they took me to lunch and they said, I know you've helped us because we had helped several members of the board with their own clinical issues. And they said, we think everybody in the United States deserves this. And I said, what are you proposing? They said, we'd like to fund something, which you're calling the Diagnostic Center. And I said, okay. They said, give us a presentation. So I had 2 weeks. I showed up at the boardroom. I asked for $3 million a year for 3 years. They basically said yes as soon as I got back to my office.
Oh.
So what we have is now a team that is a pathologist / artificial intelligence guy. We got a pathologist / engineer who used to work at Mission Control. We have a pathologist who's an informaticist, has his boards, who does anatomic pathology. We have a director of finance, a director of operations, a director of publicity. So we got 10 people, and we got a bunch of people who perform a variety of different roles. The goal of the Diagnostic Center is to figure out how to use the new tools to create something where we, UTMB, could, if you press a button anywhere, you could send your patient's information to us through a website. So far, we're not ready to open the door up completely, but we're only 34 meetings in, 2 hours every Monday. But what it means is you press the button, you fill in 20 questions, and then we take the case and we tell you what the tests are to order and what the results mean. And we don't leave you until we get a diagnosis. So that may mean 3 back and forths. But the bottom line is, we're not asking you to understand what it means to have 17 nucleotides inserted in the CYP2C9 gene, and that's why you can't respond to Plavix. So now we're taking the responsibility to do this, which means we want to build a major enterprise. I mean, we're talking about, let's start bringing DCLSs in. So now the DCLS students will have a rotation in the
Nice.
diagnostic center. They come to the meetings, they participate in the development. And so there are 2 or 3 major pieces to making this really effective to do lots of cases. One is that artificial intelligence has to look at the entire clinical record. They have to say, okay, 35-year-old woman, hypertensive, not hypertensive. These are the blood test results. And then what we do is we allow our artificial intelligence, which we have developed, to take a look at that test and then pick from dozens and dozens of comments, which we've written using large language models that are in books. Here, I'm grabbing one. The thyroid, we call them holy books. We now have 45 holy books. These are all comments. There's, as you can see, pages and pages of comments that are for Hashimoto's and Graves' disease. And so if we get your TSH and we find out everything, we can interpret that in about 10 seconds.
Wow.
Now that's the difference, because when we're doing it manually, it's 15 to 30 minutes.
Right.
Which means we
Right.
can only serve our local community. So the goal here is to build the first diagnostic center that allows artificial intelligence to look at the record and pick out everything that's important to us. It allows that same artificial intelligence to look at our potential interpretations, and then we have to look at it because we're the experts, and our DCLSs can do this as the first step. They look at it and say, whoa, not complete, have to put this in, or
Right.
this is a hallucination from artificial intelligence. Bottom line is you still need the intellect of a human.
Right.
So we look at it and say, yep, that's it. I mean, this is Hashimoto's, the TSH says this, the T4 says that, we're in. So we have created this, our 1 year meeting. What we hope to do is to do a demonstration of at least 5 different specialty teams that are fully done. And there's one other step too. We use artificial intelligence to do something called scrape the literature. So the fact is, let's say that there's a new finding. It's a genetic finding that says something about Hashimoto's. That's going to change some of the interpretation.
Right.
So what we do is we scrape the literature monthly. We allow that information to update the comments in the Holy Book. So what we have in the past, I would say April, September, so maybe about 7 or 8 months, we have new technologies we didn't even dream of 6 months before that. So I'm leading a committee that's discussing diagnostics and what the future is. And we have a person from Hopkins on it. And so, you know, Hopkins is always like one of the top hospitals in America. And so he says, obviously, we need this at Johns Hopkins too. And I said, David, you could have this at Johns Hopkins. Think of it this way. We are building the first plant that makes an automobile, like the Ford plant in Detroit. And we are not putting roofs on cars. We're just putting 4 wheels, a motor, and a steering wheel. And now we can take that and continuously improve it. And not only that, over time, there will be 25 diagnostic centers in America. The goal for us, which I think has kept us totally focused, is the patient. What we really want to do is to see that the diagnostic errors in America go as low as possible. This
Absolutely.
makes deaths on the roads seem trivial. There's more deaths from diagnostic error than all the mass shootings combined.
Right.
Every year. So the question is, everybody knows it's a problem and nobody's got an answer until now. So
That's
I can't
fantastic.
wait to turn it on for all these different areas. Like I said, we got close to 50 holy books done. We're building this automation. We just did a demo 2 weeks ago for toxicology, opioid toxicology. And we did 10 cases in 12 minutes.
That's unbelievable and fantastic. It makes me think about, have you thought about in that iteration of the scraping the literature piece that really is intriguing? Are you thinking of like a feedback loop to curriculum so that you can
Whoa,
immediate implement that into your programs?
not until you just suggested. That's a heck of a good
Outstanding.
idea. So
Sounds
that's great. I mean, certainly for the DCLS curriculum,
right,
I do
right.
think a lot of this can start at the undergraduate level. You and I should have a conversation about
We should. Sounds great. I mean, if nothing else, I mean, I've been, and I know other program directors around the country are so excited about the DCLS DMT kind of combination happening. So I think, I'm always thinking, I was a practitioner first in the lab, in the public health labs and elsewhere, but as an educator now, as an academic, I'm always thinking about how can we, I get so frustrated with, teaching to the test or the
it. Yeah,
same
right.
old things. And it's like, students need to graduate with as current from the literature as they can get, so that when they step into that role, they can, and then they need to be taught to continuously think in that way so that the curriculum is informing them all the time.
Yeah, I think that if you enter healthcare, you have to understand that yes, you have to show competence, pass exams. But in reality, it doesn't take long until your real responsibility is make sure that person who's you can
Yeah,
see in the background, who's in room 508, gets a quick and accurate diagnosis that leads to the right treatment. And that's when you know you did something important with your life.
absolutely. Let
So
me ask
that
let me
that's
ask
the
you one let me ask you one more question that just kind of popped into my mind when you say that. For laboratory professionals, and you interact with them all the time, I know. What kind of advice or what kind of thoughts do you have for lab professionals rather, in how they can become more um, confident with respect to speaking to physicians and clinicians in this role, because it's kind of new and a lot of people do have that kind of, well, until the physician, the physician knows everything, and you guys know a lot, obviously, but laboratory medicine is a huge area, as you mentioned, just talking about your
yeah.
opponent. What advice would you give to my graduates at the bachelor's level to think that
Yeah,
way?
so I think at the bachelor's level, you reach a certain level of competence where you can perform a test. And I think it's fair to say that's a pretty high level and a pretty important job. It would be hard at the bachelor's level to have the conversation about what you should do with that example I've been giving about the cardiac surgery patient. What is heparin-induced thrombocytopenia? What are the different assays? What's the confirmatory assay? How do you move on to an anticoagulant? So you don't learn that until you get more training.
Right.
So once you're in that ICU, when you're at the doctoral level training, somebody's got heparin-induced thrombocytopenia, and you're going to say, what is that in the IV fluid? And somebody's going to say, it's argatroban because we can't give heparin. The patient is HIT positive. You discuss the case the next day. So suddenly, case number one, you have like 50% of the facts in your head for heparin-induced thrombocytopenia. Then you see the second one, and then you ask more questions. After you see like 10 of those, you say, oh, okay, that might be a different form of heparin-induced thrombocytopenia. Maybe that's spontaneous hit. So it's the gaining of experience that matters. And I think that we didn't have anybody at the doctoral level in the clinical laboratory sciences area. So what happened is the doctor on the outside was trying to find out, why is the ANA elevated?
Right.
And none of the doctors were answering the question. The director of that lab did not say, hold on, I'll explain it. We'll talk about the immunofluorescence. They abdicated because they weren't getting paid. And you have to publish. So therefore, if you have to publish, then I need to get my grant. So no, I'm not talking to them. You talk to them. That isn't what happens in radiology. They get to a radiologist who gives them advice, right? It isn't what happens in anatomic pathology. They get to an expert who can say, I think it's hepatitis, not a hepatoma because. So I think it's unfair to ask somebody who's been through 4 years of post-high school graduation to have all the answers. You have to have more training. So
that clinical rounding, right,
that
is so,
clinical, right? It changes everything, right?
yeah,
It's like, okay, I get it. I remember that lady in the ICU. And really, what sticks in all of our heads are the cases, right?
right,
When I
right.
go all the way back to med school, the very first patient I saw had a disease called scleroderma. And I thought, wow. And I never forgot that autoimmune disease
Right.
because I saw that 40-some-year-old lady and I asked my attending, what do they know about fixing it? And he said, we can't, she'll be gone in 2 years. And, she was 40 something. And I thought, really?
That makes a
Never
heck of a,
forgot. So
you,
that's why the DCLS training has to, it has to intercalate so well, not only with pathology, but with medicine and surgery. And we've managed to do that here. I think that as we build DCLS programs, that's the biggest challenge, right? Because it's hard to do just with clinical lab sciences. This has to be
all disciplines.
endorsed by the institution at
Right.
the top. That's why this discussion is so important, right? Because
Yeah.
what we're talking about is creating an essential, indispensable person. And what we need is cooperation from all the clinical services, pathology especially, to educate this entire new cohort.